And so if you come across a patient with some of these parameters, how do you assess the severity and what is shock? So we define shock if shock as a state that the tissue perfusion is not adequate. So the tissues are not getting the proper blood oxygen supply, adequate oxygen supply, or the nutrient supply. And this is the state we call shock. And how do we assess the severity of shock? So shock in general, as a patient can be in stable circulation or compensated shock or hypotensial shock. So if the normal physiological status, that is stable circulation, various parameters, the conscious level, capillary refill time, how are the extremities, how are the peripheral pulses, is the heart rate normal or abnormal, how is the blood pressure, how is the respiratory rate, and what is the urine output, right? So if the patient is having normal physiologically and has a stable circulation, he is conscious, clear, and lucid, capillary refill time is brisk, less than 2 seconds, he's warm and pink, peripheral pulses, you can feel good volume pulse, heart rate is within the normal range for the age, and the same with the blood pressure, and the respiratory rate, and urine output is not less than normal. Okay, and if the patient is in shock, but it is compensated by the physiological reserves of the patient, even then the patient will be clear and lucid, though the capillary refill time can be higher than or will be higher than 2 seconds. And the peripheries are cold because it is his body is trying to compensate, compromising the peripherals and supporting the vital organs. And because of this, the peripheral pulses are weak and thready. And there is tachycardia as a compensatory measure. The systolic pressure can be normal, but the diastolic pressure will be increasing, narrowing the pulse pressure. And if the patient happens to stand from spine or sitting position, you may expect postural hypotension and syncope. Also, there is overfunctioning or overworking of the respiratory system with tachypnea. And if you happen to monitor the urine output before this shock has started, there can be reducing trend in the urine output. So this is shock state, but compensated, where the patient is conscious and clear, though there are indicators which the clinical indicators which often can be missed unless we really look for the changes, like the capillary refill, cold peripheries, weak and thready pulses, moderate tachycardia and tachypnea, and falling urine output. And then comes the hypotensive shock, where the patient becomes restless and combative. The capillary refill can be very prolonged, more than as high as 6 or 7 seconds. The skin can be mottled. Extremities are cold and clammy. The peripheral pulses are feeble or almost absent. Severe tachycardia or bradycardia. Patient can have bradycardia in the late phases of the shock. The pulse pressure is narrow, as low as less than 20 millimeters of mercury, hypotension, and unrecordable blood pressure. Even the patient might land in metabolic acidosis because of shock, and there can be Kussmaul's breathing or hyperapnea, and oliguria and anuria can also be there. So these are the clinical features that we can assess and come to some conclusion if the patient is stable or in shock, either compensated shock or uncompensated shock. So we all of us know, both as doctors and some nurses might have done their ATLS courses. So ATLS, American Society of Surgeons, in its ATLS guidelines, divided the shock, or basically this is for hypovolemic shock, into 4 grades: class 1, class 2, class 3, and class 4. There, they have parameters given, like blood loss, the absolute volume, or compared to the total blood volume, pulse rate, systolic blood pressure, pulse pressure, respiratory rate, urine output, the mental status, and the initial fluid replacement of choice. So I think we in the previous slide as well, we touched most of these parameters, except for the blood loss, both in absolute number and the percentage to the total blood volume. So the class 1, which is sort of compensated shock, blood loss can be up to 750 ml in a 70 kilo person, and the percentage of blood loss is about 15%. So up to 15%, this falls into class 1, where the pulse rate is less than 100, the systolic blood pressure is normal, the pulse pressure is normal or increased, and the respiratory rate is on the higher normal side, urine output is almost within normal limits of more than 30 ml per hour. The mental status, patient can be slightly anxious, and in this situation, the fluid of choice suggested by ATLS is crystalloid. Class 2, that is 15 to 30% of the total blood volume is lost, 750 ml to 1.5 liters. The pulse rate, there can be mild tachycardia between 100 to 120. Blood pressure, systolic blood pressure is still maintained, and the pulse pressure is narrowed because the diastolic pressure is increased. Respiratory rate increased to 20 to 30. Urine output drops down from less than normal to about 20 to 30 ml per hour. Patient is again anxious, and even here, the fluid of choice is crystalloid, the initial fluid of choice. Class 3, 30 to 40%, about 1500 ml to 2 liters. Pulse rate is again further increased. Systolic blood pressure decreased. Even diastolic blood, the pulse pressure is decreased. Respiratory rate is further increased. Urine output is almost decreased to less than 15, that is per hour. And patient is anxious and confused. Here, along with crystalloid, time to consider blood products for replacement, right? And the class 4, that is severe shock, it appears when the blood loss is more than 40% of the total body blood volume, and it goes more than 2 liters. Heart rate is high, more than 140. Systolic blood pressure is decreased, pulse pressure is decreased, respiratory rate is again increased, urine output is almost negligible, patient is confused and lethargic, so he calms down or slows down. Doesn't mean that patient is comfortable. Patient hasn't got enough of oxygen or enough of energy to become anxious or confused or agitated. And here we end up giving crystalloids and blood for treatment of this patient, resuscitation of this patient. So, where do we stand here? So this famous Starling curve, we all know. The normal physiology, if you give the fluid, the cardiac output increases, the stroke volume increases, and so the preload, you give more fluid, the cardiac preload increases, and correspondingly you see an increase in the stroke volume or the cardiac output. And that happens physiologically within a range. And if the cardiac preload has increased beyond a limit, then there is no corresponding increase in the stroke volume and cardiac output. So this is the place where your patient wants to be, or you want your patient to be. You don't want to push too much of fluid and cause the stroke volume drop, and you don't want your patient to land in pulmonary edema.